All right, everyone. Welcome to this edition of Wu University's webinar, Cosmetics, Aesthetics, and the Ocular Surface. Today's dry eye disease is a lifestyle disease by Dr. Roshni Echharam. Thank you so much for being here tonight. I'm super excited. I treat dry eye all the time, and I'm just excited to learn from you. And thanks for being
Thank
here.
you. Thank you, Elise. I'm very excited to be here and so excited for the opportunity. Thank you to U University.
Next slide. So I'm your host, Dr. Elise Kramer, and super excited to be here again. Next slide. So I will introduce our amazing speaker. Dr. Echharam, originally from Durban, South Africa, completed her undergraduate degree in optometry at the University of Durban, Westville in 1996. After graduation, she had the opportunity to work in rural Africa, where her interest in ocular disease was piqued. Due to economic instability in South Africa, Dr. Echharam immigrated to the United States in 1999. She was accepted in the International Graduates Program at the New England College of Optometry in June 2000 and graduated with a Doctor of Optometry degree with honors in 2002. Upon graduating from NECO, Dr. Echharam has worked in various retail and medical optometry settings in the US and Toronto. She maintains a strong interest in the prevention and management of ocular disease, and in August 2017, she opened her medical optometry practice, North Toronto Medical Optometry and Vision Care. At this practice, Dr. Echharam has dedicated dry eye clinic and specialty contact lens center. Dr. Echharam has lectured across Canada at various continuing education meetings on the topic of dry eye disease. Fun fact, Dr. Echharam loves adventure, travel, and cooking. Since leaving South Africa in 1997, she has lived in 3 continents and 5 cities. Wow. So when she's not working, she's often visiting a new country, learning about their culture and cuisine. That's amazing. And
Okay.
congrats for all the achievements.
Thank you. Thank
Um,
you.
Without further ado, I'll let you take it away.
Well, thank you, Elise, once again, and thank you to Wu University for this opportunity to speak tonight. Thank you to everyone that's logged in to join me on this webinar. I'm so impressed to see 972 people at 8:30 p.m. Eastern Standard Time. So thank you very much for the support. Cosmetics, aesthetics, and the ocular surface became a hot topic, specifically in dry eye disease last year with the release of the TFOS lifestyle report. So, in the next 50 minutes, I hope to leave you with some food for thought regarding pigments, particles, and preservatives that we come across in cosmetic products and how these may or may not be affecting your patients and their ocular surface disease. I hope to also encourage you to think more critically and look at the scientific evidence available regarding these particles, pigments, and preservatives so that you can better educate your patients on what's good and what's not so good, as opposed to relying on pseudoscience that's often seen on social media platforms. So these are my financial disclosures. I'd also like to give a shout out to my good friend and colleague, Dr. Laura Perriman. We collaborate on many of our dry eye talks, and I have used a few of her slides in this presentation tonight. So a brief overview of tonight's presentation. We're going to go over some commonly seen beauty offenses in practice. I will touch on innate and adaptive immunity because, as we know, dry eye disease is essentially an inflammatory condition. So you really need to know what's going on at the immunology level on the ocular surface to treat your patients effectively. We'll talk about the vicious circles of dry eye disease. Charles Baudouin and his vicious circles are never left out in any dry eye talk that I do. We'll then talk about particles and preservatives that we see in cosmetic products, some aesthetic procedures and how they affect the ocular surface, and then what's your role as a primary care optometrist. And then if we have some time, I do have an interesting case to share at the end. So I'd like to start with a polling question. How many of you that have signed in tonight ask your patients about cosmetics and skincare products during a dry eye assessment? And can we see the results of that poll? Okay, great. It's about a 50-50 tie here, so that's very interesting. Hopefully, by the end of this presentation, we can have more people incorporating this very important question as part of your intake form for a dry eye assessment, because really understanding what's going on as far as skincare goes and what your patient is putting in the periocular area is important in managing them effectively. So I'd like to start by looking at one of the most common makeup application errors we see in practice, and that's tightlining the eyelid. So these are pictures of patients that I've seen in my practice. The first one being kajal, often seen in the South Asian culture. It's applied right on the lid margin. The second one is eyeliner that has glitter in it. And the third one actually is white eyeliner. White eyeliner is said to be the sleepy girl's secret to making your eyes look more awake and stand out in a crowd. But white eyeliner or glitter in eyeliner or even kajal that's placed right on the lid margin tends to be very toxic to the Meibomian glands which rest within the eyelid. And we'll get to that a little bit later. But this is one of the most common errors that we see in our practices. So when it comes to makeup applications, particularly when it comes to eye makeup applications, bolder and more expressive applications certainly became the norm during the pandemic era, where due to the limited facial real estate brought on by masking, most patients were trying to enhance any facial real estate that was available by applying makeup in a very bold and expressive fashion that ranged from close to the lash line to posterior to the lash line to even on the waterline. And the trends included bright pigments, glitters, eyeliners. Eyeliners were inclusive of pencils as well as liquid eyeliner, and even eyeliner tattoo became very popular. Here we have our famous Lady Gaga showcasing artistic eye styling, where she's showing off a pairing of powerful, bold eyebrows with very expressive eyelids. And so in patients like this, it's very important for the eye care practitioner to take a step back, take a few photos, and educate their patients on these makeup application trends and how they would be affecting the delicate meibomian glands in the eyelid margin, or even, what's resident on the eyelid margin that patients aren't aware of, their eyelashes and the health of the eyelid margin on the whole, how it's affected by, incorrect applications of makeup. And so this was actually looked at scientifically by a study done in 2018 by Jennifer Craig and Michael Wang. And they showed that the passive or the inadvertent migration of periocular cosmetic products by poor application techniques led to tear film contamination, tear film instability, ocular surface irritation, conjunctival pigmentation, and corneal epithelial inflammation. That's a lot of data that was shown in this study. But essentially, anything that's applied here to the lid margin, when you blink, so when the top lid lands on the lower lid, gets dragged into the tear film. So you can see in this photograph of a patient that was seen in clinic, where there are little glitter particles that are now floating in the patient's tear film. And sometimes these glitter particles can be microplastics, which are very abrasive to the corneal epithelium. So, correct placement of makeup products is very, very important, and it's something that you should be educating your patients on. The second most popular trend that we see in our practices is lash extensions. And again, during the pandemic, lashes became longer and more lifted. Lashes became also darker and bolder, and often, seen with lash embellishments like glitter or even a little gems that are attached to the lash extensions. And so, again, lash extensions are increasing the patient's risk for ocular surface disease because they're doing a few things. So when Mother Nature created us, there was an ideal lid to lash ratio, and that is that your eyelid eyelashes should be 1/3 as long as wide as your eyelid. And if that ratio is kept to, then the eyelashes are actually performing a protective property. Anything longer, and now you've opened up the ocular surface to more evaporation and evaporative stress. A study done in 2016 that was presented at AVO as a presentation actually showed that in a study population of 50 patients, patients that had a lower ratio, meaning longer lashes, tended to have more dry eye symptoms because the tear film was evaporating faster. And so you were exposing the ocular surface to more evaporative stress. An interesting study also done by Allergan in 2014 showed that 3 out of 4 American women between the ages of 18 and 65 thought that their lash length, thickness, and color were inadequate. So this is definitely a trend that's on the increase, and we see it daily in our practices. So, taking the time to, again, educate patients on lashes that are too long or too heavy is important because it will exacerbate their dry eye symptoms. Furthermore to that, the lash glues or adhesives that are used often have cyanoacrylate-like adhesives in them and have shown to create a chemical conjunctivitis or keratitis. I often say to patients when I see them, with lash extensions, you often get the question like, what is the ideal length for lash extensions? Because, truth be told, some patients you just can't convince them not to put on lash extensions. So I often say that if your lash extensions are entering a room before you, then they're obviously the wrong length. So, trying to make the lighter side of things in situations like that are helpful, but also trying to educate patients on what's appropriate is equally important. Another thing that's very important to look out for is the blepharitis that follows the inappropriate cleaning of lash extensions. So often patients are afraid to wash the lid margin appropriately when lash extensions are placed. And so you have an accumulation of dead cell, debris, fungi, bacteria, all kinds of things that start accumulating along the lid margin. And these just become a breeding ground for bacteria, but also lead to a pretty aggressive blepharitis, but more so a folliculitis because the natural lash follicle becomes inflamed. So here I presented a case of a 50-year-old female that has been, again, seen in the practice, been wearing lash extensions for 15 years, and she will not go without them because her lid margin is now balding because of the constant use of these lashes. So it actually weakens the natural lash follicle. Trying to get fuller lashes in the end actually creates more of a problem than anything else. So anyway, with her taking a close-up photo and showing her the accumulation of dead cell material and bacteria that were hugging onto her natural lid margin was enough to convince her not to stop wearing the lash extensions because that wasn't going to happen, but enough to convince her that when the lash extensions are coming off or in between applications, she needs to do a proper cleanse of that lid margin to really debride the lid and remove all those collarettes in order for her to prevent herself from, developing a folliculitis. She's also had instances of preseptal cellulitis. So all kinds of lid margin inflammations that can follow from improper cleaning of these lashes, of lash extensions. Then this was another patient, a 77-year-old female that was seen in practice, and she was actually put on these lash extensions for her granddaughter's wedding and came in with a complaint of a very itchy lid margin. And lo and behold, she had a whole bunch of lashes that had matted together. And along with that, there were all kinds of things stuck within the lash extension and had become a breeding ground for bacteria. So she had, again, a folliculitis that was starting on the outer edge of this left eye. So, highlighting the importance of cleaning the lashes and letting patients know about natural bacterial biofilms that line the lid margin and how these excessive biofilms become excessive in thickness if we don't clean the lid margin properly. And that biofilm then becomes food for Demodex mites that live naturally on our skins, and an accumulation of Demodex mites is what eventually leads to more itching and irritation on the eyelash and lid margin. So moving on from there, talking about how these lash extensions and cosmetic trends affect the ocular surface, and why is this important? Well, to touch on that, we really need to understand the vicious circles of dry eye disease and where these makeup application techniques enter the vicious cycles, and what do they increase the patient's risk for. So if we think about lash extensions, I just went over that already. It increases the chances for blepharitis and eventually Meibomian gland dysfunction. It also increases the risk for viral and bacterial conjunctivitis. If we think about makeup and ingredients in makeup products, so pigments and particles, this can again cause an allergic condition like a conjunctivitis or keratitis, or certain preservatives can be ocular irritants as well. And then later on, when we touch on eyelid surgery, we're going to speak about how incomplete lid closure leads to more evaporative stress at night. And that, again, increases inflammation on the ocular surface. And it really all boils down to inflammation and how that perpetuates changes within the Meibomian gland, which eventually leads to tear film instability. And an unstable tear film will soon cause dry eye disease to become out of control. So, talking about inflammation and the immune response at the local level, meaning on the ocular surface, we really have to take a pause and understand what's happening at the immune level. And so the immune process on the ocular surface is essentially a two-step process, and it's made up of the innate immune response and the adaptive immune response. And as far as the innate response goes, I like to think of it as a very rapid onset. These are your first responders. So with a change in environment, so with the arrival of a foreign particle or a pigment in the ocular surface, it's your innate immune system that's actually activated. And this causes natural killer cells to migrate towards the pathogen, and they engulf the pathogen. It also causes the maturation of antigen-presenting cells, and these carry the pathogen to your regional draining lymph node. And it's at the level of the regional draining lymph node that your adaptive immune response is triggered. So both the innate and adaptive immune response are taking place at the same time. There's a lot of crosstalk between these two systems. And it's essentially what drives what's happening on the ocular surface. So at the level of the lymph node, with the arrival of these antigen-presenting cells, you get the expansion and differentiation of T lymphocytes. And the ones that we need to concern ourselves with in ocular surface disease are Th1 and Th17, because these are the ones that, through a cascade of events, will actually cause the release of pro-inflammatory cytokines and chemokines. And of those, the ones that are most important to us are interleukin-17 and MMP9s. So, activated lymphocytes then leave the regional draining lymph node and migrate back up to the ocular surface, where they cause the release of these inflammatory cytokines and chemokines. And this is what causes the patient to come in with symptoms of eyes burning or foreign body sensation, because it's the increase in these inflammatory cytokines and chemokines that leads to the death of corneal epithelial cells. So when you put in your fluorescein and you see epithelial defects, or punctate staining as it's commonly known as, it's a telltale sign that there is immune dysregulation going on the ocular surface, and we've got too many of these inflammatory cytokines and chemokines floating around in there. And so when you're targeting your treatment, you need to make sure that you are adding an immunomodulator or an anti-inflammatory, because you need to calm that response. By upregulating regulatory T cells, you will eventually be able to dampen the adaptive immune response and bring back tear film homeostasis. At the end of the adaptive immune response, you do have memory T cells that are formed. And these memory T cells are the ones that are quick to respond on subsequent exposure. So when the same pathogen or irritant arrives on the ocular surface, the subsequent adaptive immune response becomes faster. So you often hear about patients that have an allergic reaction and how they would come in and say that on subsequent exposure, it seems as though the onset of their allergic response is faster. And that's because now the adaptive immune system has been primed. And so the response time is a lot faster on subsequent exposure. So once again, the adaptive immune response is essentially a four-step process. It starts with initiation and then moves to amplification and differentiation. And we spoke about those T cells that get differentiated into the various forms, and Th1, Th17 being the most important ones to us. And then recruitment. So those T cells leave the regional draining lymph node and make their way up to the ocular surface. And it's the constant recruitment and reactivation of these T cells that drive the vicious circle of dry eye disease. So when you are targeting your treatment, you really need to break this T cell response in order to bring back tear film homeostasis. So that's what's happening on the ocular surface. So what is then happening below the surface? So how does all of this that's going on the ocular surface affect our Meibomian glands? Well, again, when it comes to inflammation, so eyelid margin inflammation or conjunctival inflammation or corneal inflammation, all of that leads to an increase in the melting point of meibum. And when the melting point of meibum increases, you get meibum that goes from a clear liquefied secretion to a more toothpaste-like secretion. And once it becomes toothpaste-like, the gland becomes obstructed. An obstructed gland then becomes dilated, and an obstructed gland is also a signal to the body that you don't need it anymore. So the glands then begin to truncate, and the slow process of atrophy begins and eventually leads to dropout. These meibographies that I'm sharing with you today are actually of a 28-year-old female who had a history of wearing waterproof mascara for at least 10 years prior to coming to see me. And we can see from these meibographies how compromised her Meibomian glands are. Because we all know that waterproof mascara has many chemicals in there that are toxic to the lid margin. And, it is the repeated use of those chemicals on a daily basis that eventually lead to Meibomian gland death. So Meibomian glands becoming obstructed, dilated, would eventually lead to what we see in our chairs, inflammation within the Meibomian gland, or commonly known as an internal hordeolum. Advancing lid margin inflammation, as I said, leads to a folliculitis that weakens the lash follicle, and your patient will end up with lash dropout or madarosis, as we see in the photograph on the right. Advancing microbial changes on the lid margin in the presence of inflammation also increases telangiectasia or ocular rosacea. And it's these telangiectasias on the lid margin that also spill into the ocular surface or into the tear film more inflammatory cytokines and chemokines that end up showing up as punctate keratopathy or superficial punctate staining in our patients. This, in a picture like this, it's a clear indicator that the immune system at the local level is dysregulated. The MMP9 levels in this patient are way too high. So you have to start thinking, how am I going to put out this fire? How am I going to treat this? And the two things that you need to have as part of your treatment plan needs to be an anti-inflammatory in the form of a steroid as an initial target, and then an immunomodulator for long-term control. So how do we look at cosmetic ingredients more critically? How do we know whether what our patients are using is good or bad? Well, we used to have in the past a very exhaustive list of chemicals that we would say were bad ingredients in makeup. But we've actually learned a lot over the last few years and learned that certain products within makeup ingredients aren't so bad after all. And what we've also learned is that preservatives are necessary. So in the list that I have up here, I just want to talk briefly on things that we know through clinical studies that cause damage to the ocular surface. And those would be or benzalkonium chloride that's commonly seen in ophthalmic preparations, isopropyl chlorprostonate, and this is an ingredient. It's a prostaglandin, synthetic prostaglandin analog, and it's found in most of our eyelash growth serums. And just like all other prostaglandin, just like our prostaglandin analogs, it does cause more inflammation on the lid margin and the ocular surface. Then formaldehyde donors and hydroxymethyl glycinate, which is also a formaldehyde donor. Nylon fibers, often put in mascara as a thickening agent, or rayon fibers. And then mica, which is often seen as glitter in makeup. So I'm just going to briefly touch on those few ingredients and how they could be affecting the ocular surface. So, what we've learned in the past as far as preservatives go, and as it relates to makeup, we can all agree that preservatives are necessary in cosmetic products because unpreserved or poorly preserved cosmetics are a health risk. You certainly don't want any mold growing in your makeup because that on its own is dangerous for the ocular surface. So microbial growth can lead to degradation of the ingredients and also subsequent loss of the physical and chemical stability of the product. So it's more complicated than just, preservative-free makeup products. What we know is now, as far as preservatives go, that concentrations of the preservative matter, the biochemistry matters, combination matters, and the study design matters, because sometimes poorly conducted studies actually put out information about preservatives that are incorrect. So let's look at benzalkonium chloride and formaldehyde releasing agents. Are these friends or foes when it comes to ingredients in our products? So I think we can agree that these have been scientifically proven to cause a lot of damage to the ocular surface. So we're going to call this a foe. So a study published in 2018 that looked at the effects of benzalkonium chloride and formaldehyde releasing agents on the human ocular surface and adnexal tissue found that both preservatives exert a toxic effect on the cell membranes of both the cornea and the conjunctival epithelial cells that leads to cell death or apoptosis. The study also demonstrated that aside from dose, it's the frequency of the application that played a vital role in the toxic outcomes. So if someone is using a product once a day versus 4 times a day, a patient that is on a drop that's 4 times a day is definitely going to have more damage to their corneal epithelium and conjunctival epithelium than someone that's on a once a day dosage. So frequency of dosing definitely has a direct impact on the amount of inflammation that you're going to see on the ocular surface. And this is important to think about in our glaucoma patients because most of our glaucoma medications have BAC as a preservative in it. And then let's move on to alcohol. So what about alcohols? Are they all equal? Well, it turns out that not all alcohols are bad for the ocular surface. Certainly rubbing alcohol or isopropyl alcohol is stripping and irritating, but that's rarely found in cosmetic ingredients. Sorbitol, on the other hand, is an hydroxylated sugar. Glycerol has osmoprotective properties, and it actually protects the epithelial cells from desiccating stress. So those 2 alcohols are actually okay to have in your cosmetic products and are not harmful to the ocular surface. Phenoxyethanol, this particular chemical became very popular when a study done in 2020 released some data suggesting that phenoxyethanol could be toxic to human Meibomian gland epithelial cells. But if we looked at that study more closely, you can see that the kill rate of phenoxyethanol versus control was very similar. So it wasn't shown to be more toxic than the control in this particular study. Neither was it shown to be any more toxic than methylparaben, ethylparaben when it came to human Meibomian gland epithelial cells. So again, from these studies, what we need to understand is it's not just a chemical that's toxic, but the concentration of the chemical and the combination of chemicals are also important. So when we look at phenoxyethanol and ethyl hexyl glycerin are actually synergistic. And if they're used in products together, they can actually be used in lower concentrations. And lower concentrations mean lower toxicity to the ocular surface, and they might not be as harmful to the ocular surface. So moving on to prostaglandin analogs. Now, prostaglandin analogs, again, we know have been shown to be unfriendly to the ocular surface. A study done in glaucoma patients showed that 91.7% of glaucoma patients on a prostaglandin analog had Meibomian gland dysfunction versus 58% on other classes. And so it's the same theory on prostaglandins used in over-the-counter eyelash growth serums. And because the makeup industry is so unregulated, a lot of these synthetic prostaglandins that are found in lash growth serums pass onto the shelf unnoticed. But the reality is they exert the same toxic effect. They are pro-inflammatory and so increase inflammation on the lid margin as well as at the level of the lash follicle. So, repeated use ends up causing things like orbital fat atrophy. Your patients will end up with redder lid margins. I've often seen patients that have been repeatedly using Latisse for a long time come in with their natural lashes falling off. So the inflammation at the lash follicle leads to madarosis. So it's important to educate our patients about these synthetic prostaglandin analogs and the effects they could be having on the ocular surface as well as the lid margin. Then we move on to nylon and rayon fibers. And again, these are ingredients that are found in mascara, again, used as bulking agents to make your lashes look more fuller and thicker. And everybody now wants to have a fuller, thicker lash line. So this was shown in a study done, or actually a case report found in JAMA, where a 40-year-old female presented with redness and irritation and pain in her right eye. And upon closer examination, what was found was she had several 1 millimeter long nylon fibers that were embedded within the conjunctiva, and 6 were sharp enough to penetrate the subconjunctival space, leading to ocular surface inflammation. And so often these nylon fibers, one, they're synthetic, but they're often coated with chemicals that end up being toxic to the lid margin. Parabens. So this is an interesting one. For the longest time, we said parabens are bad in cosmetic products. But if we look at parabens more closely, are they truly so bad? Parabens are actually found in nature pretty abundantly. Hydroxybenzoic acid or parabens are found in berries and in blueberries, and we eat those on a regular basis, and those aren't toxic for our system. So there was a poorly conducted study again done in 2004, a very small sample size that showed that parabens could have been the cause of breast cancer, but that study has subsequently been withdrawn. And so, if we think about parabens and look at the science behind parabens, they really aren't as toxic as we initially thought they were. Retinols. Again, retinols have acquired a really bad reputation, but not all retinols are bad for us. In fact, Flugfelder et al. In 2021 published a paper to show that retinoic acid receptors are actually found on the ocular surface. They're found in the lacrimal gland, they're found in the conjunctiva, conjunctival goblet cells, and they actually help with ocular surface healing. But there are certain retinoic acids that are bad for the ocular surface, particularly 13-cis retinoic acid. So the ones that are biologically active and found in the ocular surface are all trans retinoic acid and 9-cis retinoic acid. But the ones that are toxic or shown to increase inflammation via the Th1 pathway by the increase in the release of interferon gamma is 13-cis retinoic acid, and this is the ingredient in Accutane. Now, we all know that Accutane helps our patients with acne, but because it's drying up the sebaceous glands and Meibomian glands being part of the sebaceous gland family, it's also shown to dry up Meibomian glands. Which eventually leads to atrophy of the Meibomian glands. And this is a patient that I saw in the practice. She was 34 years old when she presented to me a few years ago with excessive Meibomian gland atrophy on her lower lids. And this is after being on Accutane for about 8 months. And interestingly, it was a dermatologist that put her on Accutane because she had acne, and she was also getting recurrent chalazion. And so her ophthalmologist concurred that Accutane would be good to get rid of the chalazion, which it actually did, but then she ended up with really dry, irritated, inflamed eyes. And so her myography showed that, over time, she actually lost a significant proportion of her Meibomian glands. Mica is an interesting ingredient as well. So mica is what gives our makeup products glitter. So it's the shine that you see in eyeshadow. But not all mica is bad for you. So mica in its natural form is a sheet silicate, and in its natural form comes in earthy colors. So if you have an eyeshadow that has off-white, silver, gold, or even a bronzy color to it, then it's probably mica in its natural form, and that's probably okay for you. Mica in its synthetic form, when it's made out of microplastics and those that are coated with pigments or dyes to give purples, reds, and blues in particular, those tend to become more ocular irritants because microplastics, once they float into the tear film, can become very abrasive on the ocular surface. And then the pigments or dyes used are pretty toxic to the ocular surface as well. So moving on to aesthetic procedures and blepharoplasties. I had a pretty large East Asian patient base, and the double eyelid surgery is very popular amongst a large population, large amount of patients within my patient base. And so, if done well, the double eyelid surgery won't lead to any subsequent issues. But when double eyelid surgeries, when the tarsal crease is not formed properly or in the correct position, it can lead to increased mechanical friction, particularly along the superior limbus. And patients can end up with a moderate to advanced superior limbic keratitis. So it's important to lift the eyelid, upper eyelid, and look very closely at that superior bulboconjunctival area, put in some fluorescein, and look for any signs of staining. Then when it comes to blepharoplasties, what we've seen through our clinical studies that combined upper and lower eyelid blepharoplasties are more common to cause dry eye disease because of the risk of an incomplete lid seal if too much tissue is removed. So as you can see in this patient here, with her eyes closed, she has a gap between her upper lid and the lower lid, and overnight that causes an evaporation of her tear film, which leads to inferior punctate staining. So I call that the smiley face sign on the cornea. So you're looking for staining along the inferior perilimbal area, and she'll also have a reduced tear meniscus height and a very low tear breakup time. So a very important test to include for patients or in all dry eye consults, but particularly in patients that have a history of dryness in the morning, you want to suspect an incomplete lid seal. As well as patients that have undergone blepharoplasties, you want to make sure that those lids are sealing well at night. So the core Blackie light test was created specifically for this. So you have the patient recline their head at a 45-degree angle, and you are going to ask them to close their eyes and shine the transilluminator through the upper lid. If the patient has a complete lid seal, you will not see any light shadow on the lower lid margin. And patients that do have a shadow, and these are patients that you need to, again, include in the treatment plan some form of treatment to treat the incomplete eyelid closure, be it wearing a nighttime sleep mask or putting in ointment or even taping the lids at night. And this is what you would typically see. So nocturnal lag ophthalmos following blepharoplasty, as I said, leads to punctate staining on along the inferior cornea. And here in this photograph, you can see with her eyelids closed, there's a big gap between the upper lid and the lower lid. And over time, this exposure will lead to increased eyelid margin telangiectasia. You'll see some thickening of the lid margin known as tylosis. You'll also see a change in Meibomian gland structure. So Meibomian glands begin to truncate, and often you can also see some notching or divots on the lid margin. So eyelid tattoo and Meibomian gland loss. So here again, we've got great studies to show that eyelid tattoo leads to a shortened tear breakup time, increased fluorescein staining, and eventual Meibomian gland loss. And so, when it comes to taking a case history and looking at the lid margin, it's very important to note whether there is any tattoo on the lid margin of your patient, so that it's again a risk factor. It's increasing. It's one factor that will increase their risk for more ocular surface disease. Eyelash tinting. This is another popular makeup trend that we see amongst our patients. And eyelash tinting, the chemicals that are used in the tinting process can lead to a severe conjunctival reaction, which leads to acute inflammation or an allergic conjunctivitis. The hydroxycinamates that are commonly used in lash tints are known to activate the neurosensory or inflammatory pathway via the TRP channels on nerve and immune cells. And these, again, cause an upregulation of pro-inflammatory cytokines, your interleukins, 1 beta, 4, and 16, and end up causing an increase in the pain and itch signaling in your patients. So they would come in with very itchy eyelids or complain of ocular surface pain. So what's your role as the eye care provider? We like to start with basics. So take a good case history, number one, but also remember an interesting acronym that I keep in my mind is ORBIT. So ORBIT stands for O is you want to clear the obstruction, B is you want to clean the biofilm, I, you want to take control of inflammation, and T, you want to bring back tear film homeostasis. So you start by having the conversation, take a detailed case history, ask about skin and cosmetic products, and then take a very close look at the lid margin. ASCARS actually put out a really good algorithm for dry eye disease. And one thing they recommend when you're looking at the lid margin is to look, lift, push, and pull. So really looking very closely at the lid margin, looking at the lash base, looking for signs of collarettes and tenting, looking for signs of telangiectasia, any notching or divots on the lid margin, really doing a thorough assessment of the lid margin to see or take a note of all the contributing factors to ocular surface inflammation, and then making a recommendation on a treatment plan. And when it comes to makeup products, I don't have any recommended brands or an exhaustive list, but I, try to have categories of good, better, best categories in cosmetics, and recommend those to patients accordingly, taking note of excessive preservatives or excessive pigments, and educating patients accordingly. So I threw this in here because this was a referral that was recently seen at my practice, and the referral said, a patient was already on compress, on omega-3 supplements, and on a lubricant, a non-preserved lubricant, but was still not feeling any better, meaning the ocular surface disease was progressing and their dry eye score was still fairly high. So at first glance of this lid margin, it was pretty evident that the lid margin wasn't assessed accurately or wasn't being treated appropriately, because you can see the tenting at the lash base. You can see the accumulation of biofilm, that this patient's blepharitis was not being addressed. This patient was not on any form of cleanser or didn't have an in-office lid debridement to clean out that biofilm. And like I said, the biofilm, if it's not clean, becomes thicker, and that leads to a folliculitis, which will eventually lead to a meibomitis, which then leads to inflammation within the Meibomian gland, and that exacerbates your ocular surface disease. So taking a close look at that lid margin, peeling down those lids, lifting them up, pushing, pulling, is very important as part of your slit lamp evaluation. And then also, as far as being the primary eye care provider, you also have to be very aware of marketing ploys in cosmetics so that you can educate your patients accordingly. The FDA's less than 1% rule regarding ingredients and concentrations is of particular relevance, especially to patients that have allergies to unlisted ingredients, because if it's less than 1%, it's not going to be listed as part of the ingredients on a product. So, being aware of that and being aware of terminology like ophthalmology tested and hypoallergenic and safe for contact lenses or safe for sensitive eyes is important to note, because a lot of these tags or labels don't have any guidelines attached to them. And so it's more just marketing than anything else. So looking at ingredients more closely and really, studying them to see whether they're really good or bad for your patient is more recommended. So I think we have a little bit of time, so I will go through this case report of a 66-year-old female that was referred to my office for a dry eye consult, and she had it all. So, it's very severe ocular surface irritation for the past year. She was using the Therapel mask and compressing once a day. She was doing some lid cleansing using a lid wipe. She was using Hylo. We get this here in Canada. It's a non-preserved hyaluronic acid based lubricating drop 5 to 6 times a day. She wasn't taking any omega-3 supplements. She tried Restasis and discontinued. And interestingly, her cosmetic surgery or her aesthetic surgery history was she had both upper and lower eyelid blepharoplasties. She also had eyeliner tattoo. And on the day that she came to see me, she had lash extensions, very thick lash extensions on the upper lid and the lower lid. Interestingly, her speed score was fairly low for the amount of inflammation that was going on her ocular surface. So you can see her osmolarity scores were very high. She had a very low non-invasive tear breakup time, which is not surprising at all. And her tear meniscus height was actually higher than I was expecting to see it, but she had a lot of reflex tearing. On slit lamp examination, noted she had eyeliner tattoo both on the upper and lower lid. I'll share her photos in a few minutes. She had lash extensions. She had a very aggressive blepharitis, extensive telangiectasia, tylosis, notching. She had it all. Her Meibomian gland, her meibographies showed advanced Meibomian gland structural changes, and her Meibomian gland secretion score was 0. So all the glands were inspissated. She had no secretions coming through. So not surprising, she had a lot of staining on her inferior bulbar conjunctiva as well as her cornea. So these are her meibographies, and you can see that there is a very advanced atrophy, shortening of glands. You've got, receding glands on the upper lid as well as the lower lid. And this was her lid margin. So her lash extensions that are attached quite poorly to the upper lid, a very red and angry looking upper and lower lid margin. And this is actually not eyeliner, but it's actually her tattoo. It's done very, very darkly on both the upper lid and the lower lid. So she had a significant dermatitis, conjunctivitis, keratitis, Meibomian gland obstruction. She had it all. This is what her corneas looked like. Very inflamed corneas, very unhappy patient for sure. So as I said, coming up with her treatment plan, I kept in mind orbit. We need to clear obstruction. We've got to clean the biofilm. We've got to control inflammation and then bring back tear film homeostasis to the best of our ability. So we started off with aggressive inflammation control. The first thing I said to her is she had to remove those lash extensions. we did an in-office lid debridement on her, and with her, she had a pretty significant incomplete lid seal from poorly done blepharoplasties. So we needed to come up with a solution for her nocturnal lag ophthalmos. And this silicone-based mask out of a company in the United States works really well. And then these stick-on patches as well for patients that cannot wear a mask are a great solution for patients that have an incomplete lid seal, because it really helps to stick those lids down and keep the eyelids closed overnight. We ended up doing a series of in-office treatments, about 4 to 6 IPL sessions spaced about 2 to 4 weeks apart. We also included at some point radiofrequency treatments. Once we had inflammation under control, I thought she would benefit from some radiofrequency to melt down those Meibomian gland secretions that were completely toothpaste-like at onset. And then this is her. She still has a way to go. Yes, her lid margins don't look completely white and quiet, but you can rarely achieve that, especially in patients that have an incomplete lid seal, as well as, very marked a tattoo along the lid margin. But you can see that her corneas are now looking very much more quiet, and she was happier. As far as her dry eye score goes, it was significantly reduced, and overall, she's doing significantly better.